Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from F. Hoffman LaRoche Limited.
This program is presented by Medscape Education Global.
Well, hello everyone. My name's Sanjay Popas. I'm Professor of Thoracic Oncology and Consultant Medical Oncologist at the Royal Marsden Hospital in London in the UK. Welcome to this discussion entitled Under the Skin, Revolutionizing Immunotherapy Delivery in Lung Cancer. So joining me today are three experts. We have Deborah Montague, who's President of Lung Cancer Europe, Luce, and Chair of ALK-positive Lung Cancer UK in the United Kingdom, Alba Silverio, who's Operational Research Nurse Lead at the Valdebron Institute of Oncology in Barcelona, Spain, and Alba Manzanek, who is Oncology Pharmacist at the Hospital Mutua de Terrassa, also in Barcelona, Spain. Welcome to all three of you. So today we're going to discuss a couple of major issues. We're going to discuss the rationale for subcutaneous use of immunotherapies in lung cancer and the underlying evidence from recent lung cancer trials. We'll discuss the role of subcutaneous immunotherapy in the current management of lung cancer, practical guidance, and how to optimize the integration of subcutaneous therapies into clinical practice, potentially using an MDT approach as well. So first of all, we're going to start off by discussing the rationale for subcutaneous delivery. Let's take a closer look behind the science of why we want to do subcutaneous delivery for lung cancer treatments. So in order to review the data, we need to remember we have three major trials that underpin this. We have trials for atezolizumab, pembrolizumab, and nivolumab. And also, interestingly, not immunotherapy, but targeted agent, we have data on subcutaneous amivantamab, which I'll also talk about as well. So moving on, first of all, to subcutaneous atezolizumab. Now, this is co-formulated together with recombinant human hyaluronidase, which is the standard approach for all subcutaneous treatments, which is approved in the European Union for all approved indications of intravenous atezolizumab. It's also approved in the UK and also in the FDA jurisdiction. Now, the data that supports it comes principally from the IMSkin 001 and 002 trials. Here, we are discussing initially the IMSkin 002 trial design. Here, patients with a metastatic lung cancer who were chemo-naive with TPS more than 50, or also early-stage lung cancer who had resection and completed adjuvant chemotherapy with PD-L1 1% or more were randomized to either receive subcutaneous or intravenous atezolizumab. This was for 3 cycles, and thereafter they were crossed over for a further 3 cycles. And at the end of that, they were given a choice to go back to either intravenous or subcutaneous for a further duration of 6 cycles. And the primary endpoint of the study was to look at the proportion of patients who preferred atezolizumab subcut versus IV at the cycle 6, day 1 time point. And so what did the results show? Well, clearly, in terms of patient preference at the primary time point of evaluation, the vast majority, nearly 71%, preferred subcutaneous usage versus 21% who had IV preference. And the main reasons for this was either less time, more comfortable, or less emotionally distressing. And importantly, when patients were given the choice at the end of the initial 6 cycles treatment period, the vast majority, 79%, actually voted to continue with subcutaneous, demonstrating really the important clinical utility of subcutaneous versus IV. Importantly, in this study, the time taken to prepare the subcutaneous formulation by nurses and pharmacists was also evaluated, and the time taken by nurses was markedly lower than by pharmacy. And this is because subcutaneous dosage can be prepared outside of the pharmacy in the ward setting and does not require the typical sterile conditions that, for example, a cytotoxic or intravenous would. And in fact, this resulted in a 3 times faster preparation time compared to in pharmacy. Now, when the adverse events were looked at in the table that you can see here, the adverse events are highlighted for atezolizumab subcutaneous to IV arm and the IV to subcutaneous arm. And if we look at the cycle 1 to cycle 3 adverse events in both of these arms, you can see they really are very, very similar. Indeed, if we look at the penultimate row, which is the AEs leading to treatment discontinuation, we really have very similar results. When you look at cycle 4 to 6 columns in both of these arms, again, we get very similar results as well. So we've got no new particular safety signals associated with the route of administration. But importantly, if you're switching between sub-Q and IV or the other way around, regardless of the sequence, it really was well tolerated. Now, the trial before this was the IMSkin-001 trial, which looked at the PK of the different formulations, but also looked at the efficacy. And in this data set with a mature overall survival analysis and progression-free survival analysis, you can see here that both the sub-Q arms in blue and the IV arms in red are really performing almost identically as well, reassuring us that there really is no change in efficacy or detriment for the subcutaneous formulation. Well, what about subcutaneous pembrolizumab? So this is not currently approved by EMA or the FDA. This is in May 2025 on recording, but is coming to us. And this is underpinned by data from the D77 trial. And this was a randomized phase 3 trial of patients with metastatic non-small cell lung cancer without EGFR, ALK, or ROS1 genetic alterations who were randomized to receive either chemotherapy with pembrolizumab, subcutaneous, or intravenously. And the primary endpoint were PK-based endpoints. And if we look at the primary endpoints, we look at the PK-based endpoints at cycle 1. They were really very similar geometric mean ratio between the two different modalities of administration. And at the steady state, that cycle 3 C-trough ratios, we can see that the geometric mean ratio is again very similar. And we have no meaningful differences between those two. Now, when we look at the efficacy, we see that the efficacy was really very similar. The PFS is no different between the two formulations. And when we look at the response rates, again, no meaningful differences. The forest plot on the right really demonstrating no major differences. So we're confident in terms of the PK and the efficacy. Well, what about the safety? When we look at the safety, again here, we see no real differences in incidence of treatment-related grade 1, 2 in the dark colors and grade 3, 5 in the light colors, treatment-related adverse events between the subcutaneous formulation and the intravenous formulation. Of course, we do have some minor adverse events at the injection site, as would be expected with a subcutaneous formulation. The newest kid on the block is subcutaneous nivolumab, which has an FDA and UK MHRA approval, currently awaiting EMA approval. And this is based on the Checkmate 67T trial in renal cancer, which is a randomized open-label phase 3 trial of sub-Q Nivo versus IV Nivo in previously treated patients with advanced or metastatic renal cell carcinoma. Here, subcutaneous nivolumab demonstrated non-inferiority of the co-primary PK endpoints and PK-powered secondary endpoints of response rates. And when we're looking at the safety outcomes and health-related quality of outcomes, these are really very similar between the sub-Q and IV formulations. In terms of regulatory status, the FDA and UK MHRA have approved sub-Q Nivo every 2 weeks or every 4 weeks after chemotherapy, and the FDA also has approved it 3 weekly in conjunction with neoadjuvant chemotherapy. I guess the other drug that is available in lung cancer, not immunotherapy, is amivantamab, which is a bispecific antibody targeting EGFR and MET. Now, this is approved for use by the European Commission, and it's approved weekly and fortnightly first line in combination with lazertinib for common EGFR mutant lung cancer and after platinum as monotherapy for exon 20 insertion positive non-small cell lung cancer. Now, the data that supports this comes from the sequence of Paloma 1, 2, and 3 trials. Paloma 3 was a trial of patients with EGFR mutant lung cancer who had disease progression after osimertinib and platinum-based chemotherapy, and they were randomized to receive amivantamab and lazertinib, with amivantamab delivered either subcutaneously or in the other arm intravenously. In terms of the primary endpoints, this trial demonstrated that subcutaneous formulation was non-inferior to IV amivantamab in terms of the PKs, and also in terms of efficacy, very similar in terms of the response rates. But what was quite interesting was that there was a signal of perhaps increased efficacy with progression-free survival with a hazard ratio of 0.84, not statistically significant, but surprisingly, overall survival was statistically significant. Now, this was not powered as a secondary endpoint and needs further investigation and validation, but is an interesting finding. When we look at the safety of subcutaneous amivantamab, this was, by in larger terms, very consistent with intravenous, but there are far fewer infusion reactions, 13% versus 66%. So that's the data on our subcutaneous formulations. Let's transit to discussion. Let's talk about how do we optimize the integration of subcutaneous therapies into clinical practice, and what do we do to make things happen? Just some clinical scenarios for thought. Which patients might we think of where a subcutaneous option may benefit certain populations? Well, I've been thinking about this, and actually nearly every patient I come across wants to spend at least time as possible in the hospital. So I do think not only for patients that are young, patients that are working, patients that are elderly, don't find it easy to get to the hospital, that a subcutaneous formulation might be very useful. And it may be in a scenario where you're using IV because you're using it in conjunction with chemotherapy, but then you stop your chemotherapy, you're moving on to maintenance treatment, and then you may want to go to subcutaneous formulation. Then I'm thinking about, for example, in extensive stage small cell lung cancer, chemotherapy with atezolizumab, you might want to give the atezo IV if you're giving IV chemo anyway, but then move to subcutaneous for the maintenance phase. But I'm going to bring in Deborah to the conversation because I'm always interested to hear from the patient and caregiver perspective. Deborah, from the patient caregiver perspective, what guidance do you think you should give to us in the clinical teams with regards to subcutaneous formulation or IV for individual patients? Is this something that patients would want, and what's the approach we should take?
I think the theory is that yes, most patients would want subcut formulation, and the data that you've already shared suggests that. I think it's important that the patients are spoken to around their concerns. They might have questions around, will this work as well as IV formulation that they might have already been on or expect to receive. Concerned about side effects, and I think giving patients time, maybe with the nursing teams, to answer all their questions and make sure all their fears are addressed. So it's very much part of the shared decision-making process with patients. We know that patients feeling empowered actually gives them, a much better quality of life, and also in terms of doing better because they feel empowered. So yeah, and I also think being aware of the support services that might be available, to share those with patients.
What about information, Deborah? Do we have to give different information for the sub-Q versus IV to really highlight those differences? I presume we will, right?
Yes, and I think it will be important to ensure that patients understand what the differences are, and what the benefits are. So it might not be obvious to patients initially that there is a real benefit to being able to have subcut formulation. So the reduced time in the chair and therefore overall time in the hospital setting, I'm sure most patients would welcome. So from that perspective, sometimes the benefits aren't obvious to patients. They're more concerned about, well, will it work? So yeah, laying things out in a very clear, easy to understand way will be important.
Thank you. I think that's really, really important advice for us. I'm going to ask from the nursing perspective, my colleague Alba Silverio, how